Assalamu alaikum. I hope you guys are doing well in this pandemic situation. So, our today's topic for online lectures is dengue fever and dengue hemorrhagic fever. These are two different entities, dengue fever and dengue hemorrhagic fever. Dengue fever is a benign syndrome and caused by several arthropod-borne viruses, like they are carried by the mosquitoes. And the fever is characterized by biphasic pattern, along with myalgias, muscle pains or arthralgia, joint pains, and rash and leukopenia, decreased white cell count, and lymphadenopathy, means swelling of the lymph nodes. And the dengue hemorrhagic fever is a severe, often fatal febrile disease caused by dengue viruses. It is characterized by capillary permeability, abnormalities of hemostasis, and in severe cases, a protein losing shock syndrome, dengue shock syndrome, which is a kind of more severe form of dengue hemorrhagic fever, and it has got some immunopathologic basis. There are at least four distinct antigenic types of dengue virus, which is a member of the family Flaviviridae. In addition, three arthropod-borne viruses, arboviruses, cause similar or identical febrile disease with the rash. So these are like Toga virus, it causes chikungunya, and the vector is Aedes aegypti or Aedes africanus. So vector means the mosquito in this situation. So these are the name of mosquito, Aedes aegypti and Aedes africanus. And the distribution wise, this causes disease in the region of Africa, India, and Southeast Asia. Similarly, Toga virus causes annoying and the vector is the Anopheles fenestis. And flavivirus causes West Nile fever, and the mosquito, the vector is Culex molestus and Culex univitatus, and it causes the distribution area is the Europe and Africa and Middle East India. This is the diaphragmatic, diagrammatic presentation of Aedes aegypti, and showing a larger size mosquito along with the strips on the body, and this is a clear view of strips. Epidemiology wise, dengue viruses are transmitted by mosquitoes of Stegomyia family. Aedes aegypti is a daytime biting mosquito, and it is a principal vector, and it carries all the four types which have been recovered from it. In most tropical areas, Aedes aegypti is highly urbanized, breeding in water stored for drinking, bathing, rainwater collected, so it is usually found in the fresh water. Dengue viruses have also been recovered from Aedes albopictus and other, you can say, species of Aedes. Dengue fever and dengue-like diseases are now endemic in tropical Asia, the South Pacific Islands, northern Australia, tropical Africa, and some other region. This is the distribution, the diagrammatic view of the map. Areas like Pakistan, India, Bangladesh, Sri Lanka, and some parts of Australia, and the red areas are, usually in the past or presently there may be some epidemic activity in this area. Most cases occur in older children and adults because Aedes aegypti has a limited flight range. So the spread of an epidemic occurs mainly through the viremic human beings and follows the main lines of transport. So if a human being is infected from the virus, he can transmit the disease like the other healthy mosquito will bite and the infected human being and will get the virus, and carry the virus and will bite the healthy human being and then transfer that virus to the healthy human being as well. So sentinel cases may infect household mice mosquitoes. A large number of nearly simultaneous secondary infections give the appearance of contagious disease. Where dengue is endemic, children and susceptible foreigners may be the only persons to acquire overt disease. Adults have become immune. Dengue hemorrhagic fever occurs where multiple types of dengue virus are simultaneously or sequentially transmitted. So repeated infections from different strains of the viruses. Pathogenesis. So dengue fever is a mosquito-borne viral disease caused by one of the four closely related but antigenically distinct serotypes of dengue fever, like serotype 1, then 2, then 3, and then 4. Infection with one dengue serotype confers lifelong homotypic immunity from the same strain, I mean to say, but it gives only a brief period of partial immunity to the other strain, like for 2 years almost. When dengue virus immune complex attached to macrophage FC receptors, a signal is sent that suppresses innate immunity, resulting in enhanced viral production. Absence of cross reactivity causes um, like the absence of cross-reactive neutralizing antibodies and the presence of enhancing antibodies from passive transfer of or active production are the best correlates the risk of dengue hemorrhagic fever. What does it mean? Like as I already told you that there is an absence of cross-reactivity to the other strain, and similar at the same time when the virus is attacking our immune system, there will be enhanced antibodies. So these both things will collectively increase the risk of dengue hemorrhagic fever. This is the diagram showing the cycle of dengue virus transmission. Virus basically is transmitted to human by the saliva of the mosquito when it bites to the human being. Virus replicates in the target organs, and then virus infects while blood cells and lymphatic tissues and of the human body, and virus is released into the circulation in the blood, and then again if the healthy mosquito bites this infected person, that mosquito will get infected and will transmit the infection to the again to the healthy human being. What are the clinical manifestations? The incubation period is 1 to 7 days. So in during this period there will be no symptoms, but the viral will replicate inside the body. In infants and young children, the disease may be undifferentiated or characterized by fever, non-specific fever for 1 to 5 days, and with the signs of upper respiratory tract infections. A majority of infected older children and adults experience sudden onset of fever with temperature 103 or 106, usually accompanied by a frontal or retroorbital pain, particularly when pressure is applied to the eyes. Occasionally, severe back pain precedes the fever, back break fever. So it is usually severe body aches, which a person experiences just before or after the fever. A transient macular generalized rash that blanches under pressure may be seen during the first 24 to 48 hours of the fever, along with myalgia and arthralgia. From the second to sixth day of fever, nausea, vomiting are apt to occur, and generalized lymphadenopathy, cutaneous hyperesthesia or hyperalgesia, taste aberrations, and pronounced anorexia may develop. About 1 to 2 days after defervescence, a generalized morbilliform maculopapular rash appears that spares the palms and sole, and it disappears in 1 to 5 days. Rarely there is edema of palms and soles. About the time the second rash appears, the body temperature, which has previously decreased to normal, may become slightly elevated. So this is which I have already told you, the biphasic pattern of temperature. Now coming to the dengue hemorrhagic fever manifestations. A relatively mild phase or first phase similar to the dengue fever, like fever, malaise, vomiting, headache, anorexia, and cough, is followed after 2 to 5 days by rapid clinical deterioration and collapse. In this second phase, the patient usually has cold, clammy extremities, a warm trunk, flushed face, diaphoresis, restlessness, irritability, mid-epigastric pain, and decreased urine output. Frequently, there are scattered petechiae on the forehead and extremities. Spontaneous ecchymosis may appear, and easy bruising and bleeding at sites of venipuncture are common. A macular or macropapillary rash may appear, and there may be circumoral and peripheral cyanosis. So this is the picture of a severe case of dengue shock syndrome or dengue hemorrhagic fever. Respirations are rapid and often labored. The pulse is weak, rapid, and thready, and the heart sounds are faint. The liver may enlarge 4 to 6 cm below the costal margin and usually firm and somewhat tender. Approximately 20 to 30% of the cases of dengue hemorrhagic fever are complicated by dengue shock syndrome, and fewer than 10% of patients have gross ecchymosis or gastrointestinal bleeding, usually after a period of uncorrected shock. After 24 to 36 hour period of crisis, convalescence is fairly rapid in the children who recover. Diagnosis is usually made by the PCR. And another very important test is NS1. It's a viral non-structural protein. NS1 is released by the infected cells in the circulation and can be detected using monoclonal or polyclonal antibodies. WHO criteria for dengue hemorrhagic fever are fever for 2 to 7 days in duration of biphasic, minor or major hemorrhagic manifestations, thrombocytopenia less than or equal to 1 lakh and per cubic millimeter, and objective evidence of increased capillary permeability, that is hematocrit increased by more than or equal to 20%, because the fluid comes out of the vessels and hematocrit increases. When fluid comes out of the vessel, there will be pleural effusion or ascites on the chest radiography or ultrasonography or hypoalbuminemia. Dengue shock syndrome criteria include those of dengue hemorrhagic fever, this above, as well as hypotension, tachycardia, narrow pulse pressure, less than or equal to 20 millimeter. Pulse pressure is the difference between systolic and diastolic pressure, and signs of poor perfusion, cold extremities. So this is a kind of more severe form of dengue hemorrhagic fever. Other lab investigation, there may be pancytopenia, there can be neutropenia, platelets counts may fall rapidly, and the tourniquet test result may be positive. So what is the tourniquet test? If we inflate the blood pressure curve between systolic and diastolic pressure for 5 minutes, then there can be petechiae 10 to 20 in number in the cubital fossa per square inch. Then we can say the tourniquet test result is positive. And rentangiogram of the chest reveal pleural effusions right more than left in nearly all patients with dengue shock syndrome. The differential diagnosis of dengue fever includes like dengue-like diseases, viral respiratory and influenza-like diseases, the early stages of malaria, mild yellow fever, scrub typhus, viral hepatitis, and leptospirosis. Because meningococcinia, yellow fever, other viral hemorrhagic fevers, many rickets, shield disease, and other severe illnesses caused by a variety of agents may produce a clinical picture similar to dengue hemorrhagic fever. The etiologic diagnosis should be made only when epidemiologic or serologic evidence suggests the possibility of a dengue infection. Treatment. The treatment of uncomplicated dengue fever is supportive. Bed rest is advised during the febrile period. Antipyretics should be used to keep body temperature less than 40, less than 104. Analgesics or mild sedation may be required to control pain. Aspirin is contraindicated and should not be used because of its effects on hemostasis. Fluid and electrolyte replacement is required for deficits caused by sweating, fasting, thirsting, vomiting, and diarrhea. What is the management of dengue hemorrhagic fever and dengue shock syndrome? Management of dengue hemorrhagic fever and dengue shock syndrome includes immediate evaluation, vital signs, and degrees of hemoconcentration, dehydration, electrolyte imbalance. Close monitoring is essential for at least 48 hours because shock may occur or recur precipitously early in the disease. Patients who are cyanotic or have labored breathing should be given oxygen. Rapid intravenous replacement of fluids and electrolytes can frequently sustain patients until spontaneous recovery occurs. Normal saline is more effective in treating shock than more expensive ringer lactate saline. When pulse pressure is less than or equal to 10 mm mercury, or when elevation of the hematocrit persists after replacement of fluids, plasma or colloid preparations are indicated. Transfusion of fresh blood or platelets suspended in plasma may be required to control bleeding. Salicylates are contraindicated because of their effect on blood clotting. Disseminated intravascular coagulation may require treatment. Hypervolemia during the fluid reabsorption phase may be life-threatening and is heralded by a decrease in hematocrit with wide pulse pressure. Diuretics and digitalization may be necessary. What could be the complications? Fluid and electrolyte losses, and hyperpyrexia that can cause febrile convulsions in children. Epistaxis, petechiae and purpuric lesions are uncommon but may occur at any stage. Swallowed blood from epistaxis vomited or passed by rectum may be erroneously interpreted as gastrointestinal bleeding. In adults and possibly in children, underlying condition may lead to clinically significant bleeding. Infrequently, after the febrile stage, prolonged asthenia, mental depression, bradycardia, and ventricular extrasystoles may occur. So, in adults and in children in which underlying conditions like some preconditions, they are already having any blood diastasis and blood problems, bleeding problems, clotting problem, that may lead to significant, clinically significant bleeding. And not frequently but infrequently after the febrile stage, prolonged asthenia, mental depression, bradycardia, ventricular extrasystoles may occur in children. Prognosis: dengue hemorrhagic fever, especially death, has occurred in 40 to 50% of patients with shock, but with adequate intensive care, death should occur in less than 1% of the cases. Survival is directly related to early and intense supportive treatment. Infrequently, there is residual brain damage due to prolonged shock or occasionally to intracranial hemorrhage. Thanks very much for your listening, and you can ask any question on the YouTube section of the lecture. Thank you.